Welcome to the ASCO eLearning Weekly Podcast, a weekly educational series focused on helping learners identify knowledge gaps and stay up to date with the latest in new drug developments, cancer treatments, and patient care approaches. This episode is complimentary to an education session presented at the 2019 annual meeting. For more detailed information about the education session, make sure to check the episode description for links to ASCO's meeting library.
Hello, my name is Jonathan Goldman. I am the Director of Clinical Research in Thoracic Oncology and the Associate Director of Developmental Therapeutics at UCLA. This podcast is entitled, Why Doesn't Checkpoint Inhibitor Immunotherapy Work for All Patients? Mechanisms of PD1 Inhibitor Resistance in PDL1 Overexpressed Tumor. I will review two cases with eminent physicians in the field to explore these issues. I spoke with Dr. Edward Guerin regarding an elderly woman with adenocarcinoma of the lung. Eddie, thank you for joining us.
Thank you.
This woman is 78 years old, a prior smoker, and previously healthy despite moderate emphysema. She presented with back pain and had a lesion encompassing the thoracic vertebrae T7 to T9. An orthopedist stabilized the vertebrae, and an excisional biopsy was consistent with adenocarcinoma of the lung. PDL1 was 50%, a KRAS mutation was found, and all other mutational studies were negative. Staging showed a right lung primary, regional lymphadenopathy, and no CNS tumor. Adjuvant radiation to the bone was performed. How do you select her initial systemic therapy?
So there isn't absolute agreement on what the initial systemic therapy should be in a patient who has PD-L1 expression of 50% or greater in the setting of EGFR and ALK wild-type disease. There are two data sets, both of which showed striking benefit over standard chemotherapy. One was single-agent pembrolizumab, and the other was, and this is not one study necessarily, but one of several studies that have shown a benefit to adding a PD-1 or PD-L1 inhibitor to chemotherapy, either with or without an angiogenesis inhibitor. I think that there are multiple considerations that go into this. I think that in patients who are particularly elderly or are of limited performance status, that's a patient population where I think most of us would clearly choose single-agent pembrolizumab to manage the care. On the other hand, patients who have rapidly progressing or bulky tumors, sometimes people will consider chemotherapy along with a PD-1 or PD-L1 inhibitor. There are ongoing studies that are looking at this question, but to date, clearly either of these approaches would be appropriate in this patient.
And just to pin you down, on an average patient, let's say mid-70s, pretty good performance status with a high PD-L1 and no other pushing factors either way, what have you generally done?
I have generally used single-agent pembrolizumab in that setting.
Very good. Thank you very much. So this patient did begin pembrolizumab-based therapy. This was soon after the initial report of the combination therapy benefit, and she was started on the triplet with carboplatin and pemetrexed. She tolerated treatment well, had a good partial response. 18 months later, she presented with a headache and had a new 1.5 centimeter right frontal brain metastasis. She was radiated with stereotactic radiosurgery. In this situation, would you change her systemic therapy?
So I think this is a very difficult question and one we don't have great data for yet. Traditionally, we have treated single metastasis in the brain differently, and our reason for that is that we know that many of our therapeutics do not do a good job of getting into the brain. However, in some of our newer therapeutics, both targeted agents and also the PD-1 and PD-L1 inhibitors, we have seen evidence of activity in the brain. That being said, in a patient where the only site of sort of escape is in the brain, as is the case in this patient right now, assuming that other scanning is unremarkable, I would not be inclined to change systemic therapy. I would be more nervous than I was about the efficacy of this therapy prior to the brain metastasis, but I would not yet be willing to declare that the immunotherapy is unsuccessful. I would be more inclined to radiate this lesion and continue with her systemic therapy as is being done.
And that is what we have done. And that actually brings us up to the current time for this patient. There is now new evidence of systemic progression as well. Although there are many causes, or there may be many causes of loss of response to PD1 inhibitor therapy, do you conceptualize or categorize them in any way?
So there's become a lot of enthusiasm about sort of biologically subdividing this disease. But in the end, I'm not sure that we're there yet in terms of our ability to meaningfully determine that. There are research ways that we can look for certain mechanisms that would be associated with loss of response, but they certainly are not what I would consider to be clinically relevant at the moment, or at least clinically doable. We're not going to be conducting extensive whole genome searches on patients in our routine practice. The one grouping that I do differentiate is really based on clinical grounds. And we already got into that issue a little bit in this patient when there was a single metastasis. I have found that there certainly are a group of patients who have had really what I would describe as an escape lesion. So one area that has grown where the rest of the disease really was maintained under control. And in those cases, I would say anecdotally, I have had great success in treating with radiation, on some occasions radiofrequency ablation, or even surgery, in having those patients continue to do well over long periods of time. On the other hand, there is unfortunately a group of patients for whom the progression looks very much like progression on carbotaxol used to look, and or carboplatin paclitaxel. And in that group of patients, I have not been enthusiastic about maintaining the immune checkpoint inhibitor, and instead have looked to move to additional therapies or different therapies.
Particularly in the clinical trial world, are there certain directions that you think are most promising in this drive to overcome secondary resistance?
So I must admit, to some extent, I've had some disappointments in the studies that are looking to combat resistance to PD1 inhibitors. As full disclosure, I participate and have conducted many of these studies, but I am concerned that different patients are presumably becoming resistant to immunotherapy in different ways, and that the idea of treating all patients who are resistant to immunotherapy sort of the same may not be based on great biologic rationale.
Thank you very much. I think we really covered a lot of ground with one patient, and that was very helpful. Thanks for your time.
Thank you.
Thank you for listening to this week's episode of the ASCO eLearning Weekly Podcast. To make us part of your weekly routine, click subscribe. Let us know what you think by leaving a review. For more information, visit the Comprehensive eLearning Center at elearning.asco.org. The purpose of this podcast is to educate and inform. This is not a substitute for medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.